Okay, I think we can start. This webinar is being recorded. So welcome everyone to our webinar today. A few housekeeping items before we get started. In today's webinar agenda, we will discuss the diagnosis and treatment of retinal angiomas, often the first manifestations of VHL. This webinar will be recorded and we will send out the YouTube link as soon as possible to all the people who have registered. The video will also be posted on the VHL Rare Connect community. A few reminders before we get started. Audio will be made available through your computer speakers, and due to the large number of participants, we will be muting all the microphones during the webinar. Please feel free to ask questions at any point during the presentation using the Q&A button located at the bottom bar of your screen. By clicking on the Q&A button, a pop-up will appear. Participants just need to type their questions here, and the speakers can either type a response or say it out loud. The rest of the participants can also comment on these questions. This webinar also has a chat room. So when clicking on the chat button, the chat box will appear on the right side of your screen. You can use this feature to talk to all the panelists as well as all the webinar participants. We will reserve some time at the end of the presentation to answer your questions, and we will do our best to answer as many questions as possible throughout today's webinar. If you're having difficulties viewing the PowerPoint presentation, please make sure you have a stable internet connection. And the audio quality might also be better if you use headphones. And with that, we will open today's webinar. We are very lucky to have with us Dr. Nikolaos Bechrakis, Professor and Chair of the Department of Ophthalmology in the University Clinic Essen in Germany, and also Dr. Valérie Krivosic from the Hôpital Lariboisière, in Paris, a reference center for rare vascular diseases of the central nervous system and the retina. And with that, I'm going to stop sharing my screen and I'm going to hand it over to Dr. Bechrakis. So feel free to start whenever you're ready. I hand it over to you.
Thank you very much. It is my pleasure to participate in this webinar. I'm quite excited because this is the first time I'm in a webinar. I haven't done that before. So as you heard, I am a doctor specializing in ophthalmic oncology. I'm working in Essen in Germany. That is one of the 2 or 3 big centers for ophthalmic oncology in Germany. So today's topic will be on Hippel-Lindau disease, and I'm very happy and honored to be able to do this together with Valérie Krivosic, who is a renowned expert in this field, having had a lot of publications about this issue. Let me start. I'm starting because with Valérie we decided that we would separate the topic in diagnosis and screening or surveillance of the disease, and then that will be my part, and Valérie will take over on the treatment issues, and I will talk about in about 15 to 20 minutes. So with regard to Phacomatoses, this is a Phacomatoses issue. Phacomatoses the term Phacomatoses derives from the Greek term phakos, which means lens, and the term lens or spot on the skin. So if you have any kind of skin spots, there is a number of syndromatic diseases that you can see here on the panel. Neurofibromatosis type 1 or 4, Recklinghausen's disease. It's one of them, tuberous sclerosis complex. Traditionally, the disease called von-Hippel-Lindau disease or retinocerebellar angiomatosis is one of the Phacomatoses. However, most of these patients don't have any lens spots on their skin. But there is also the Sturge-Weber disease that has a very well-known stain on the face that is associated also with Lewis-Parr-Poitz-Jeghers disease. With regard to ocular manifestations of Phacomatoses, as I just mentioned, the most prominent and most common, although it is not very common in general, it's von Hippel-Lindau's disease, the retinal cerebral angiomatosis, Such-Weber's disease, and the so-called racemose hemangioma that actually is not a hemangioma, but is a communication of the retina and the vein in the area of the retina. On terminology, von Hippel-Lindau. Von Hippel was the ophthalmologist, von Eugen von Hippel, that first described retinal angiomas. Arvid Wilhelm Lindau is a pathologist from Scandinavia, Sweden, that described the pathological features of the disease, and actually the syndrome was described in Denmark as an autosomal dominant pedigree. And when we discuss about this disease, we know that it has many manifestations. Some of them, most of them are on the retina hemangioblastoma. That's why we speak here as ophthalmologists to you, but there are also cerebellar angiomablastomas, spinal hemangioblastomas, other tumors that are benign, pheochromocytomas that has to be diagnosed early because of the exacerbation of the blood pressure. Pancreatic cysts that are benign, but also kidney cysts and consecutively renal cell carcinoma that we have a really good chance to diagnose these diseases quite early and treat them early. So von Hippel-Lindau disease has been successfully linked to the mutation of the VHL gene, and this was done by several investigators, most prominent in the typing and the identification of the von Hippel-Lindau disease gene as present on the chromosome 3p2526 was by Latif some 20-25 years ago. It is a typical tumor suppressor gene, and as you know from or might know from the Knudsen two-hit hypothesis, you need to have two mutated alleles of this chromosome in order to have the disease. So since this is an autosomal dominant disease, it is transmitted from the parents, and if the kids have one of the mutated allele, then they need a second hit, and this is the second hit, and then they have both alleles mutated, they will get the disease. This gene, more precisely, the product of this gene is a regulator of the cell cycle, and if you have this mutation, there is variable but very high penetrance of about 90%, and on the other hand, if you have the disease, there is not always a complete expression, but it's a variable expression of the disease. So once again, it is on chromosome 3, the gene product is PVHL, and the function of this gene is to suppress hypoxia-inducible factor expression that is very important for angiogenesis, metabolism, anaerobic metabolism, and proliferation. And it has an interaction of various cytokines like VEGF, transformic growth factor, alpha, epidermal growth factor, erythropoietin, and others that are very important to be in homeostatic status. Otherwise, the tissue has the impression that it is in an hypoxic state, and it produces, if it is in this state, angiogenesis. This is why we have the production of these vascular tumors, and a similar pathogenetic approach. You have the development of cysts in various disease areas, and also, as I said, renal cell carcinomas. With regard to the frequency of this disease, it is a rare disease. The prevalence is about 1 in every 50,000 people, so it's rare, and it occurs in about 1 to 40,000 live births approximately. So the incidence is about half of the incidence that we have in another very rare disease that is inherited in ophthalmology, that is retinoblastoma. Retinoblastoma is 1 in 20,000 live births. So this is even rarer. In Germany, I calculated that since living in Germany myself, about 1,000 patients that have this disease, and in the state that I'm staying, about 350 patients with this disease. There is a debate about how do you classify this disease. If you have a positive family history, you need only one manifestation of VHL, and I showed you the different manifestations, which is hemangioblastomas of the eye, brain, and so on. So only one manifestations is enough. If you have a negative family history, you need at least 2 manifestations, either retina or central nervous system, or one of the central nervous system or visceral lesion. It is enough to, as an international criteria, to have the definition of a VHL disease. It is important to know that if we have 2 hemangioblastomas, at least 2 hemangioblastomas, then we have not a one singular angioma in the eye that might not be necessarily associated with VHL. We have, by definition, a VHL syndrome if we have 2 manifestations. On the other hand, it's important to know that if we have only one manifestation, even then we can have von-Hippel-Lindau's disease, and about 40% of patients have, even with one manifestation in the retina, von-Hippel-Lindau's disease. So it's important, even if we have a singular solitary retinal hemangioblastoma, to rule out this syndromatic disease. How do we screen? And there is a traditional so-called Cambridge protocol published by Maher and co-workers, where you screen involved VHL patients on an annual basis with medical exams, abdominal ultrasonography, urinary tests to rule out pheochromocytoma, and obviously you need to rule out retinal hemangiomas by ophthalmoscopy. Until the age of 50, MRI scans of the central nervous system every 3 years, and then further on every 5 years. And about, with regard to the relatives of these patients, it is similar, but a little bit more loose, this screening criteria. The last years, we know that, since we know that this is a genetic disease, we can spot really the gene, the mutation of the gene suppression product in the gene, which is located on chromosome 3. So we can, by a simple blood test, we can detect this mutation either by DNA sequencing or by other molecular genetic analysis, by Southern blot analysis, FISH or MLPA. And we have a detection sensitivity about 95 to 100% in patients that have typical features, but only in 25% approximately in patients that lack this disease, these typical features. And we must encounter that there might be some mosaicism in some 5% of VHL cases. So it is, although the genetic diagnosis is very, very good, it is not absolutely perfect. And with regard to screening and surveillance, the Danish group has been very active in this regard. And so the screening up to the age, from birth to the age of 4, you make pediatric exams and ophthalmoscopy as good as it is possible, and pupillary dilatation every year once. However, the probability to have VHL manifestations until the age of 4 or 5 is quite low. So it is not that, not done in every country of the world by this. way. After the age of 5 and until mid-adolescence, until 14, annual exams, also ENT exams, audiology, ophthalmoscopy. You check for pheochromocytomas, and you have to check for cerebellar or CNS hemangioblastomas by magnetic resonance imaging, and also check the abdomen in patients, candidates, not patients, but candidates that are in school age. So after the age of 8, where you can do this exam on the, and the children tolerate this exam. Under the age of, over the age of 15, you have again on annual basis ophthalmoscopy examinations of the retina, and every 2 years MRI scans for the central nervous system. For us ophthalmologists, it is important to know that if you look at this graph here, you see that the probability to have a retinal hemangioblastoma comes first at the age, can I show this with my pointer? It starts at the age of approximately 5. So screening in this area, yes, you can do it, but probably you won't find anything. So after the age of 5, the probability of getting retinal hemangioblastomas is becoming more and more. And with a time lag of approximately, if you look at this time lag here, 5 to 10 years, there are cerebellar hemangioblastomas that arise. And a time lag of even more 20 years later, you have renal cell carcinomas. So we ophthalmologists come into play in this area here, at the age of 15 approximately, where 20% of patients, 30 and so on, at the age of between 15 and 25, something like that here, 1/3 of all patients have retinal hemangioblastomas, and we can instruct the patients for the risks of this syndrome. It is basically one of the responsibilities of the ophthalmologist to do this. You can see here again the probability, the incidence of the manifestation of retinal hemangioblastoma and the time lag of cerebellar. So really the first thing that occurs is retinal manifestation, then come the brain, and then come the kidney. This is a typical spinal hemangioblastoma that you can see here, that occurs in about 50% of all patients. Cerebellar that you can see here. Usually it is in the cerebellum. It can be in the pons or somewhere around here. It's quite rarely in the brain. Renal cell carcinomas that you can see here in this picture. These are cysts, and pheochromocytomas in the later age. What is important is to make as early as possible diagnosis of these systemic manifestations in order to avoid these kind of really large tumors that cause a lot of mortality in these patients, in order to reduce mortality of these patients. Chromocytoma in 25% of patients. This is a typical example of a retinal hemangioblastoma in a post-mortem eye of a patient that unfortunately died due to massive brain hemorrhage of von-Hippel-Lindau's disease that was not early diagnosed. You can see this specimen here, and you can see how this hemangioblastoma in the retina in the very early phase looks like. So it is a typical hemangioblastoma in the retina. You can see that there is cystoid edema of the retina and some hemorrhage around it. And also one of the important issues is that there can be traction here. This is the other eye, the second eye of this patient, where you can see traction due to vasoproliferative proliferation into the vitreous. And these things need to be avoided in this stage of the disease, of the retinal disease. It is extremely difficult, as Valérie will, I'm sure, tell you in a few moments, to treat these patients that have retinal detachment and traction or retinal detachment. In an analysis that we did some years ago with my colleague and friend Klaus Martin Kreusel, you can see that there is a wide distribution of retinal hemangioblastomas in the retina, around the retina, in the periphery at the equator. So there is not only a distribution in a specific area, but note one detail, that you have quite a lot, you can have quite a lot hemangioblastomas around and over the optic disc. This is a particular challenge. I'm sure Valérie will talk about this. It is extremely important from our point of view to have a very early diagnosis of the retinal hemangioblastomas. And as you can see in this picture on the left side, it is quite difficult in ophthalmoscopy to spot one of these hemangiomas. This is one that is noted here with the arrow, but it's very, very difficult to see this on pure ophthalmoscopy. But if you do a fluorescein angiography, it is very easy to see these white spots. So this is one of the tools that you need to have in mind to do a wide field fluorescein angiography in one of the screening examinations in order to see the angiomas in a very early stage, because it is quite easy to treat them in this stage, as you will hear. This is another example of a very small early microangioma that you can see, but you can see this very nicely on fluorescein angiography. These angiomas become bigger. You see the dilated vessels around the angiomas, and this basically is the hint to see these. If you see these vessels, tortuous vessels, then you can spot these, but in the early stage you don't see any really tortuous vessels. So this is difficult to diagnose, and this is probably impossible to diagnose without fluorescein angiography. But this is easy, and of course this is very easy to diagnose, but these are relatively late stages where you have retinal detachment, traction. It is quite difficult to have a very good result after the treatment of these patients. So Valérie will talk about this treatment options in retinal hemangioblastomas. I would just like to repeat that screening needs to be done in these patients. It is different in different countries, where you have different recommendations by the societies, and there are not really official recommendations, but as you saw from the statistics, you have retinal hemangioblastomas basically starting at the age of 5. So in Germany, we propose to start with a screening at 5, the same in the Netherlands, and so on, and then on an annual basis. In order to have early diagnosis, it is important to stress the syndromatic issue about this disease, that the patients can have brain problems, cerebellar hemangioblastomas. They need to be diagnosed early in order to have early treatment with good results and avoid bleeding of these tumors. They can be deadly if they bleed, and even in these areas, if this hemangioma in the spine bleeds, you will have a paralytic person then. And obviously, in order to avoid these massive renal cell carcinomas that you see here in these patients. It is important to note that there is an increased mortality of these patients. This very nice statistics that you see from Denmark, from the 1900 until today, basically, you see that of normal patients, the survival of normal patients has increased by time. The same has happened in the dotted line on the VHL patients. Males have a better prognosis than females. I don't know exactly why this is, but it increases the survival of these patients due to good surveillance, which is, again, one of the most important things. And also, you see that patients that have a VHL, they have a worse prognosis comparing to their siblings. So this is a one-to-one comparison. This is a brother or sister of a patient with a with the disease, and you can see that female patients have a little less prognosis than male. I would like to thank the good collaboration to our patient organizations that are extremely important in getting the message across to our patients and helping us in discussing these problems with our patients. In German, it's the Verein von Hippel-Lindau. And there is this organization, VHL.org, where you can see also the age and screening recommendations that are recommended by these patient organizations. And with that, I would like to thank you for your attention. This is our department, and of course I need to acknowledge all these people who are working together with me and us in the ophthalmology department in order to have the treatment of these patients. So thank you very much.
Thank you. I see there's a question on the Q&A box. Do you want me to read it out loud?
Let me see how I can go back to this.
Yeah, just click on the stop button on the top.
Oh, there is, the question is there a rationale to stop screening at a certain age or prolong the intervals? Basically, no. Patients with age, the probability of developing problems is, you saw the line that goes up by time, so it is basically recommended to have annual screening examinations. This is what is recommended.
Okay, there's a second question.
I would say, why don't we go on with Valérie's?
Okay, we can continue.
Then we can have all these questions together and discuss these all together.
Yeah, that's perfect. Perfect. Yeah. I just need you to stop sharing your screen so Valérie can share her.
Stop. Yes. Did I do it?
Yes, yes, you did. So Valérie, whenever you're ready.
Okay, I can start. Hello, I'm Valérie Krivosic and I work in Lariboisière Hospital in Paris. We're going to talk now about treatment. We have recently published the guidelines of retinal capillary angiomas of von Hippel-Lindau with the Emily Chu team. And as it was said, the pre-symptomatic diagnosis of the lesion is very important. The detection of the other lesion of the body is also important. And considering the retinal lesion, the most important is to treat, whenever it is possible, all the lesions which are detected. Okay. And the goal of the treatment is to...
Do you want to share your presentation?
You can see the slide?
No, no, you need to share it using the green button at the bottom.
Oh, so I saw it was done.
Sorry.
Okay.
Okay, yeah, now just go to presentation mode and yeah, continue from there.
Okay, can you see, everybody can see?
Yes, yes.
Okay, thank you. So the goal of the treatment is to destroy the vascular tumor, and it will depend on the size, on the location, because if the lesion is on the peripheral retina, of course, we can use aggressive treatment, which will destroy the lesion, but also the retinal tissue around the lesion, like thermal laser, cryotherapy, or surgery. When the lesion is on the papilla, we can't use those treatments, and we have to use treatment that will preserve the nerve fiber. And of course, the treatment will depend on the repercussion on the lesion and the tissue. That means the amount of fluid or the presence of attractional retinal detachment. So the treatment is optimized by the diagnosis of pre-symptomatic lesion. And in France, we have our center for rare disease of the brain and of the eye in Hôpital Lariboisière. But there is also le Centre Prédire, which is led by Professor Richard, and all the patients with VHL disease is registered in that center, and it helps the patient to see the specialist who can take care of them properly. So let's start with small lesion. We really have a preference for laser photocoagulation for retinal capillary hemangioma. And here you have the example of a small lesion, less than 1 disc diameter. We deliver the impact directly on the lesion, and we have to use impact with a lens long enough to allow the diffusion of the energy into the lesion, and the intensity has to be high enough to whiten the lesion in order to destroy it. The technical property of the laser allow perfectly to do that. Usually it doesn't cause a lot of pain, but if it is, we can perform it under anesthesia. This is in other cases. You can see here 2 small lesions. The vessels are dilated. And here you see the patient 6 months after only 1 laser session. The lesions are now totally white and fibrosed. And as you can notice, the vessel returned to a normal caliber, which is really an indirect sign of good photocoagulation of the lesion. So we have published a large series of retinal capillary hemangioma treated by laser, and there is a cut when the lesion is less than 1 disc diameter, and when the lesion is more than 1 disc diameter. And when the lesion is small, it is really easy to treat it with laser, and we have 100% of succeed in that lesion. It has already been observed by other teams. There is not that many publications which describe the result of laser photocoagulation for retinal capillary hemangioma, but most of them agree with the fact that this is a good treatment, this is a good option for a small lesion. When the lesion is bigger, like this one, 2 or 3 diameters, laser can be performed, but you really have to follow the patient during the first day and the 2 first days of treatment, because this situation can be worse after the first laser session. As you can see here, there is an increase of the retinal detachment. There are fluid in the macula, and if you don't do anything at that time, it can be very, very bad for the patient. So we have to perform more laser photocoagulation session, and we finally can occlude during the first day or the 2 first days the lesion and stabilize the situation. And here is the patient 3 months after the lesion. The vision is not that good because there are still exudate in the macula, and it will take a few more months to go over, but the vision can be quite good, and the hemangioma is completely occluded in fibrosis. The difficulties is when the lesion is 3 disc diameter or more. Here the laser could be not enough, and it could be difficult to have a complete occlusion of the lesion by only laser. Here is an example. You can see the patient 1 week after laser. It is black on fluorescein angiography. That means that there is no blood in it. But when I saw the patient 1 month after the laser, you can see that nearly nothing is done. It is still pink. There are still blood filling the lesion. The vessel is still dilated, and laser was not enough. So I performed some more laser, and in those cases, you can perform also just 1 impact of cryotherapy, which allowed to occlude the deeper part of the lesion. And in our series, we perform finally cryo in 25% of those large retinal capillary hemangiomas, and it allowed to destroy it totally and stabilize the situation. We perform cryo always after severe session of laser photocoagulation. Let's see now the more complex cases. We stay with the same patient. Unfortunately, she disappeared for a few years, and after 3 years of follow-up, when she came back to the hospital, she had this tractional and exudative retinal detachment of the posterior pole. Her vision was very low, and here you can see the location of the hemangioma that I treated years ago. It is occluded, there is no blood in it, but there is vascular and fibrous proliferation over the retina. There are more small retinal capillary hemangioma which appeared. And so in those cases, we have to perform surgery because laser is clearly not enough. So we start always the vitreoretinal surgery by vitrectomy. We have instrument that cut the vitreous and allow to go very close to the retina and section and allow to detach all the membrane and the proliferation at the surface of the retina. This is a quite difficult surgery. You have to be very careful not to make a hole on the retina. You have to detach all the membrane from the all the hemangioma which are now treated and fibrosed. This surgery, bleeding can occur during surgery because if the hemangioma are not totally occluded, and if you pour it a little bit too harder, it can block during the surgery. So you have to stop to perform laser to coagulate at every step of the surgery in order to control the visibility during the surgery. We have also forceps, and you can use bimanual surgery in order to make a very delicate dissection of all this membrane which are stuck on the retina. Okay, there we are. Okay, and this is another way to identify the membrane. You can use dyeing, and the membrane appear blue when it's easier to dissect them. And this is the last and most difficult part of the surgery, the temporal peripheral part of the retina. Here you can see there is a very thick membrane, but it was again possible to dissect it and take it, and clean totally the retina. Where is it? Here. And at the end of the surgery, you can put some gas or silicone oil in the eye in order to facilitate the cicatrization of the retina. This is another case of a complex form of retinal capillary hemangioma with a subtotal exudative retinal detachment. In that case, once again, you can't perform properly the laser photocoagulation, and we have to perform surgery. This is the fundus after surgery. The retina is flat. The hemangioma is totally fibrosed. The vision is not that good, but the patient can keep an eye. We have published our series of surgery. We had 23 cases. There was only a few publications in the literature. So the vision is not usually that good, but the patient can keep an eye. And as you can see, 1/3 of the patient was blind. In another series, there was more patient who was bad eye after surgery. Let's move to papillary retinal hemangioma, papillary hemangioblastoma. This is the cases of a small one, which is here just at the upper part of the papilla. I could follow the patient from 1995, and I still follow this young lady. The vision is quite good, and the hemangioblastoma has grown a little bit, but the vision is still very good. So this small lesion seems to have a very seems to have very little progression. This is a case which is much bigger, and there are some edema of the macula. In those cases are more difficult to manage, and the treatment can cause severe vision loss. Here you see the filling of the lesion during fluorescein angiography. So the treatment of this lesion is very difficult, and so you have to perform treatment only if the vision is seriously decreased. And it appears that the combination of anti-VEGF injection and dynamic phototherapy can help in a lot of cases. There are a few cases in the literature who seems to agree with that hypothesis. This is the case I've just shown you. 1 week after one session of treatment, one session of laser with an injection of anti-VEGF. As you can see, there are more edema, the situation is worse. So at that time, I perform another session of laser, and it can help, and the edema decrease, and the vision come back, and it can help the patient for many years after that. This is a larger cases of a young patient who has also other systemic implication of von-Hippel Lindau. The vision was low because there was a neovascular membrane prepapillary. So I decided to treat the patient by dynamic phototherapy and anti-VEGF, which works, and the hemangioma, but there was a retraction of the neovascular membrane occurred, and it was not good for the retina. There was a tractional deformation of the macula, and the vision became worse. So I performed surgery, removing all the membrane, treating the hemangioma, allow secure surgery without any bleeding, and it really helps the patient. He is now 20/20. So surgery for papillary hemangioblastoma could be performed, but only if there is an hyperretinal membrane or tractional retinal detachment of the posterior pole, and you have to prepare the surgery with anti-VEGF and dynamic phototherapy in order to occlude the hemangioblastoma and decrease the risk of bleeding during the surgery. A few words, sorry, about systemic anti-VEGF. So in Lariboisière, we try with Professor Richard two cases a long time ago, and it was not the student, it was the molecule which was developed just before, and it worked on exudation. That means that the patient had less macular edema, but there was no modification of the volume of the tumor, and there was really a toxicity. So we stopped there. And a few years ago, we tried the sunitinib in a few patients in France with Professor Richard. Only patient with very severe lesion could be included in the trial. So we proposed to this young lady to perform it. There was a lot of retinal capillary hemangioma on the posterior pole, on the periphery. At the beginning, maybe I had the impression that there was a regression of the lesion. As you can see, the diameter of this vessel seems to be not that large a few weeks after the beginning of the trial, but it was just a wrong impression, and after a few months the situation was worse in the eye, and the patient did not tolerate well the treatment, and we have to stop it. So this is the result of this trial, and the conclusion that was that there was no effect of sunitinib of vascular lesion. Maybe it can help on solid lesion, but not in the vascular lesion of von Hippel-Lindau disease. So to conclude, the goal of the treatment of retinal capillary hemangioma is to destroy the lesion whenever it is possible. Visual prognosis of small lesion is very good, so laser photocoagulation should be applied to every peripheral lesion less than 1 disc diameter, and this is why the presymptomatic diagnosis of those lesions is so important. And the treatment of larger lesion is more complex, but everything can be done, and we have to try, and it required a careful follow-up of the patient. So in Paris, the patient, I take the patient in our referral center, Le Cerveau. Thank you.
Yeah, thank you very much. If you want to stop, excellent. Yeah, I see there are some questions asked by the participants. Do you want to read them, Valérie?
Yes, but I can't see the question, I'm sorry.
Yeah.
I don't know what happened.
Yeah, go to the Q&A button at the bottom of the screen. It has...
Okay, do you think there is a rationale to use anti-VEGF because surgical treatment? Yes, I think. The rationale is that anti-VEGF can decrease the vasopermeability of the vessel, and also it creates a vasoconstriction. So maybe it can lower the risk of bleeding during the surgery. So usually I do that, and I do also an intravitreal injection at the end of the surgery. Have you used propranolol? And if yes, what are the results? I've tried propranolol in only one patient. He also has hemangioblastoma of the spinal cord. He was more than 40, and the vision continued to grow. So we tried, but unfortunately, after 1 year, there was no efficacy on the size of the lesion of the eye, and the hemangioma of the spinal cord had grown. It increased, so it was not a good try. I've seen that the Spanish had tried in 7 patients, I think. It doesn't change anything on the volume of the tumor again, but they had the impression that the patient did not develop anymore any lesion in the eye. So maybe it can help. We have to do more work on that. What is best to do if the vision of one eye is lost? To put the eye off, or how can we reverse it? It depends the reason why the vision is off. Usually if the eye is nice and the patient wants to keep it, there is no reason to take it off. The only reason to take an eye off is that, of course, you don't see with it, and it is painful, or it is not nice. Are there new surgical techniques in addition to radiofrequency and laser or on trial at the moment? Do they offer any hope? Virtual retinal surgery is becoming more and more efficient, but not only for VHL patients, for all the patients, and we can use all those techniques for our VHL patient. But there is no trial specifically for VHL patient right now. Okay, is there other question? Yes. What are your experience with regard to complication when tumors are treated with cryoablation? I don't have any experience in retinal plaques. So
I can comment about that.
Yes.
Yeah, I have quite an experience with ruthenium plaque. So first of all, we use ruthenium plaques for thicker, bigger tumors, because as Valérie said, smaller tumors, approximately at the order of 1.5 millimeters in thickness to 2 millimeters maybe of thickness, we can do nicely laser ablation with various techniques. But in thicker tumors, I prefer personally ruthenium plaques. It is nice to have a ruthenium plaque, a small one, and one that it has a relatively low dose rate in order to avoid these massive exudative reactions that you have, that you can experience, that you saw on the pictures Valérie showed with the laser treatment, for instance. Similar exudative reaction you can have with ruthenium plaques. My impression is that cryoablation, if you don't have ruthenium plaques, is not a very good option, because cryo makes a lot of exudation, makes a lot of reaction of the tumor. You need to do a lot of cryo in order to freeze the whole amount of the tumor, and this causes a lot of exudation. Another option that I could discuss is photodynamic therapy. And also in very, very selected cases, we have tried proton beam irradiation. I don't know your experience, Valérie, with proton beam irradiation, since you have this in Paris. But in cases where you have the most difficult cases of von-Hippel, Lindau's or retinal hemangioblastomas, are the papillary hemangioblastomas. You don't have really a good option to treat them.
Yeah.
And if you do laser, you will destroy the optic nerve. If you do photodynamic therapy, we don't really know what will happen. It has been proposed for many, many years that you should not do this on the optic disc. I think this is relative by now. I think you could do photodynamic therapy on the optic disc, but nobody wants to do this really. So one alternative option is to do proton beam irradiation. I must say, we haven't published this, but the results are not really very good. But it's one option that you have. Other option could be to do surgery, and during surgery to make some endocriocoagulation on the tip of the iceberg. But every case is different, and it's very difficult to treat these patients.
Okay.
Any other questions?
No, I don't think so. Now is your time if you want to ask questions to the speakers. Otherwise, I'm going to finalize this webinar and upload the recording to YouTube, so I can send you a link probably early next week to all the participants, also the panelists, and I will share the link on the Rare Connect community. So I think there are no questions. So thank you everyone for your participation. It's been a very dynamic discussion. I want to thank you, the speakers, for finding the time and dedicate some of their time for this topic. And thank you to all the participants who have joined us today, this Saturday.
Thank you very much.
Thank you. Thank you, Nikolaos. Very nice talk. Bye-bye.
Bye-bye. Thank you all.